It always hurts. So there's one that's ongoing, but
when did you first notice it?
Years ago. Okay. But it gets worse with my job now.
What's your job?
I look after mice in a lab, in a science lab.
Oh wow.
Yeah.
What does that look like posturally?
You're like this constantly.
Okay.
All day, every day.
Okay. Is there anything that makes it better or worse?
Rest.
Okay. What makes it worse? Doing this all day?
Working is a problem.
Any particular movements that you're aware of that really?
No.
Can you pinpoint the pain? Can you point to
sometimes it starts there and then goes all the way down.
Okay.
Sometimes it's up in my neck, so it's like.
Okay. So what's the muscle that we might think of when Charlie just mentioned it starts there and goes up into my neck?
Left scapula.
Yes. So that's just on my radar at the moment. From experience, the levator scapula is going to be the victim of something else that's happening around the shoulder. Girls being pulled into a position that it doesn't like. So that's also something that we want to think about. Do you ever get any referral pain down the arm at all? Any tingling, pins and needles, anything like that?
No, sometimes my fingers go numb when I've got a muscle stuck, but apart from that.
Tell me more about that. Do you feel it, the numbness all the way down the arm, or is it just...
No, just in the fingertips, in two, normally.
Which ones?
These two.
Ring and middle?
Yeah.
And I know this is difficult to differentiate, but I'll explain why I'm asking this as well, because the median nerve innervates 1, 2, 3 and a half, and the ulnar nerve half and 1, like that. So can you differentiate between the inside and the outside of the finger, or does it just feel like the two? You can?
Yeah.
And is it on the inside?
It's just in the top of both fingertips.
Okay. And is that the times when this is really acute?
Yeah.
Oh, right, okay. So what other symptoms, syndromes might be coming to mind with numbness in the fingers?
Impingement. Every now and then.
Maybe less shoulder impingement, although we will do those tests.
Oh,
So there's thoracic outlet syndrome. Yeah, which goes hand in hand with the, that kind of shoulder position. That's going to be troubling things as far as levator scapula goes. That can be impinging the brachial plexus, which is giving us the neural stuff, or this carpal tunnel. I'll be thinking more along the lines of thoracic outlet, but there are tests that we could do to see that. Okay. And while we're there, we're going to look at shoulder impingement just to clear that. Sorry, I'm in your way.
no, it's fine.
Palms face up to the ceiling. Thumbs down. Arms in. So that's your empty cam test. And this is the add-on to that. She's not in any pain. Pushing to match my pressure. Good. And down. So I don't feel any weakness there. Any pain when you do that? Pretty much rule out shoulder impingement. Then it would have been triggered. Bring your left arm onto your right, like that, and then lift, and then push. This is the scarf test for acromion inflammation. And then right onto left, lift up. Pain?
Wow, it's just stiff.
Okay. Arm back down. And okay. Also, while I'm doing this, I'm not coldly analysing someone's posture. While I'm doing these tests, that's when I'll have a look and see what's happening with this shoulder here that's not going on with that one.
It's lower.
Yeah, it's a little bit depressed. So this is then...
That's right.
This is then where you might be starting to think about which muscles depress the scapula. If it's depressed as well, naturally I'll come in and just have a look here and see if we've got any protraction of the scapula. My fingers are coming into that space where pec minor would be pec major, and we're just seeing what's the gap like there. Is it rolled forward? Is it not? And I would say yes, a little bit compared to the left, but we'll have a look at that on the couch objectively. Let's look at the rotator cuff as well. So if you bring your elbows into your side like this, and then rotate out. Good. And if you get any pain, just let me know. Arms back down. Can you bring your left arm up behind your back like this, and then turn around and show me? Good. Back down. Now right arm as well. Any pain there?
Up here, yeah.
Okay. A little bit of restriction there as well. Arm back down. Anything else that we could do there, do you think, as far as shoulder assessment? When you think in actions of the shoulder, you might even go as far as thinking horizontal adduction, abduction, extension, all these kinds of things. I think a lot of those can be tested on the couch. These are the major tests that you might want to look at. So it's not an exhaustive shoulder assessment, which is what we might see in clinic. What have you got underneath your t-shirt?
Bra.
I have a normal bra.
Yes.
Okay. That's not relevant. Turn around and face that way then. So we won't strip off your bra, but we'll have a look. Bony prominences. Oh, okay. There's the inferior angle of the scapula. You can see that right side's a bit depressed. But always make sure to check the superior angle as well, because, good, it's level. So what's going on there? Any guesses? Depressed compared to the level.
It's got a massive scapula on one side.
Valid. Yes. The scapula moves in every plane pretty much. It doesn't just work in elevation depression, but it also works in protraction, retraction. So what that might give us is a clue that this is actually protracted to some degree, or there's something else off here. But always check those two bony prominences, because that can just give you a little clue, and it's just quite interesting to see. Might also just palpate the spine and see, have we got any protraction on the right side? And I would say a little bit. Again, we can see this. What I'm looking for from you, Charlie, is hands against the wall, however you want to do it really. Press up position. So these are level with shoulders, shoulder width apart. I want you to squeeze your shoulder blades together and then press them apart.
God, I remember trying to do this and I couldn't work it out.
Yeah, that might tell us something. Great, so let's just have a look at how you do it first of all. Squeeze shoulders, push them apart. That's not too bad. Okay, squeeze together, push them apart. Squeeze together, push apart.
It's not moving as much.
If you watch this shoulder, it is trying to figure something out along the way. So just do that movement a couple more times.
Yeah, could you step to the left, please? Thank you.
Maybe try and get yourself there, so you can see. So as Charlie protracts, which is serratus anterior trying to work, it's trying to figure something out there. I'm going to palpate here as well, so inferior angles. So squeeze together and push apart. And there's also a little bit of elevation. So there's a couple of cues that we can give here that might help. They're not going to help Charlie because it make it more difficult to do. It's going to help serratus anterior to work. So when you do it, I want you to focus on really keeping these shoulders depressed. So try not to elevate and shrug. Squeeze together and then push apart.
Oh.
So there's a lot less movement there. We know serratus anterior depresses. So as soon as we start to elevate, we've lost serratus anterior. So this could be an exercise straight away that we might want Charlie to do. We want it to build strength.
Is that why she might be the levator scapula compensating, talking about that being shortened? Because
Yeah, possibly, because of the elevation there as well. So anytime she should be using serratus anterior, her body's finding other ways to do it. Yeah, so it's illustrated by this wall press. So one more time, keeping the shoulders depressed. Try and keep them where they are. Squeeze together and push apart. It's there, it's happening, and you find that in the first few reps. But what this is about, it's not just about building strength in serratus anterior, but also building that mind-muscle connection, those neural circuitry that it needs to try and upwardly rotate the scapula. The uppercut press is perfect for that. And I use this quite a lot for clients. It's a difficult one to explain because quite often people, all they see is a movement. And what they see here, even if they're not gym literate, is a shoulder press, which is that. Well, that's an Arnold press, isn't it? But they want to get the arm up here. But actually, serratus anterior uppercut press is more like that. All we're looking for is scapular upward rotation. That's it. And they should be able to pop their fingers in here and feel that muscle working. So give that a go with the left first of all. So we can use this as another form of assessment. So you're keeping the arm facing, I want that wrist facing in towards you the whole time. Try and get everything nice and straight. Good. And then just press up. Good. And that's all we need. So I'm going to come behind and palpate serratus anterior. Press. And go. Good. Like with the scapular press, is a muscle that's often underused. So she might not feel this for a little while. Just consistency and faith in the process. All right, let's try this on the right side then and see how that feels any different. Any difference there for you?
No, just tighten my shoulder.
Okay. I can feel less movement in that scapula there as well, so this might be like an active mobilisation for you. One more test then before we then to get onto treatment. I think we'll look at shoulder instability.
This is for your serratus anterior.
How's that feeling?
It's fine.
Okay.
So lovely.
Could you go, doing it in front of a group of people is like the icing on the cake. Could you go into a full press up position, like this? Try it on, so put your weight on the left arm first. Good, and now try on the opposite. Any pain there?
No.
Okay. So straight off the bat, I think it's a good sign there's no pain there. There's some work that probably you can stop.
Thank God.
There's some work I think that needs to go into that press up position. And that would be an end game product of the scapular wall press. The serratus anterior is the difference in the press up position from that to that. And you'll get that from the wall press and slowly increasing that down to a raised surface and then eventually press up position from the floor. Relax the arms. This is that mobilisation that we do. I'm also going to use this to see what kind of movement have we got. Does that scapula lift up off the rib cage? And then from there we can see if we've got elevation, depression, downward rotation, upward rotation, protraction and retraction. And those 6 movements all strung together are a mobilisation. Let's assess that compared to the right side. So bring your arm behind your back on the right. Relax. Interestingly, I can't actually get my hand in there quite as well as I could have done. So just relax for me. Deep breath in and out. Well, there's a bit of improvement. I can definitely feel some tightness. Does anybody know the action of serratus anterior as it relates to the rib cage? Fixes the medial border of the scapula to the rib cage. So there might be a little bit of inhibition here, but also tightness. So I think we need to do some work in mobilising the shoulder straight away. A bit of guarding there as well. Is that painful?
Yeah, a little bit, yeah.
Okay. And what bit hurts? Does you want to push up like that?
Yeah.
Okay. So just relax. Just go a little bit more gentle. Some slow circles. Pain?
No, not yet.
Ever the optimist. And obviously we can get into the soft tissue around the scapula, 17 muscles that connect to that, try and get some more movement out of that. But the passive assessment shows us there's a bit of restriction there as well. So there's another little thing for your treatment plan. Yeah. So there is a special test, of which I can't remember the name, but it's something like that position there. We're putting everything under tension, you're palpating the pulse, and you're seeing if in that position, it takes about 1.5 minutes for the pulse to then fade. And if it does, that's a positive for thoracic outlet syndrome, because the vascular structures in here are being impinged to the extent that they're restricting the blood flow. And then I want you to extend the wrist. Try and get those fingers all the way up. Good. And then very slowly lean your head to the right. Okay. And then back down. So what we're doing there is extending the median nerve and all the other neurostructures here distally, and then we're applying that last bit of tension proximally on the nerve. So that's what it should feel like. If you're giving that as an exercise, don't do it like that. Make it more of a floss or a glide, which means that you're slackening the nerve from one end as you're extending it from the other, and then doing the same. Like that, on a glide. And now we'll repeat that on the right side. So arm out like this. Extend the wrist, fingers extended, and usually that's too much. As long as that feels okay and tolerable, slowly bring the head that way. How's that for you?
Oh, so nice.
How's it feel compared to the left? Better, worse, or the same?